Welcome everybody at this first webinar in a series of 3 webinars. These webinars have a focus on rare coagulation disorders and are a collaboration of the International Society of Laboratory Hematology and the European reference networks EuroBloodNet. The main objective of this program is to distribute knowledge and give visibility in the advances in the field of rare coagulation disorders. The disorders that we will address are factor XI deficiency, inherited fibrinogen disorders, and hemophilia, all diseases with an impact for patient management and treatment. In the program, we will address the pathophysiology, the diagnosis, and the treatment of these disorders. After the presentation, there is a Q&A session with the attendees, and at the bottom of your screen, you can see a Q&A button where you can add your questions in. But all webinars will also be recorded, and the videos will be integrated into the ISLH and the ERN-EuroBloodNet e-learning environments. The webinar of today is on laboratory aspects and management of factor XI deficiency. It is my pleasure to introduce the speaker, Dr. Chee Wee Tan. Dr. Chee Wee Tan is a clinical and laboratory hematologist and director of the Hemophilia Center at the Royal Adelaide Hospital in Australia. He is the immediate past president of the Thrombosis and Hemostasis Society of Australia and New Zealand, and the treasurer of the executive committee of the Australian Hemophilia Centre Directors Organisation. He is vice president of education of the International Society of Laboratory Hematology, and he has also served in a number of committees of the International Society of Thrombosis and Hemostasis. His main interests lie in aspects of clinical and laboratory hemostasis, including bleeding disorders, thrombosis, platelet disorders, and thrombotic microangiopathies. So today he will talk on the laboratory aspects and management of factor XI deficiency. Please, Jiwon, the floor is yours.
Thank you very much, Katrien, for the kind introduction. My name is Dr. Chee Wee Tan, and today, as Katrien mentioned, I'll be discussing laboratory aspects and management of factor XI deficiency as part of the collaboration between ISLH and EuroBloodNet on the webinar series focusing on rare coagulation disorders. So I will start by discussing the structure of factor XI and its role in coagulation, followed by the prevalence of factor XI deficiency, the clinical phenotype, and its relationship with factor levels. The diagnosis and management of factor XI deficiency will then be reviewed, and the presentation will conclude with an outline of key issues concerning factor XI inhibitor development. So the factor I molecule is a plasma glycoprotein serine protease. It is synthesized primarily in the liver. It is a homodimer consisting of 2 identical subunits linked by disulfide bonds. Factor XI is a component of both the intrinsic coagulation pathway and kallikrein-kinin system. Hence, factor XI plays a role in both hemostasis and the inflammatory response to infection and/or injury. Factor XI as a zymogen is activated to factor XIa. Factor XI can be activated by factor XIIa, thrombin, and also through the process of autoactivation upon exposure to polyanions such as DNA, RNA, polyphosphates, and NETs. Figure A on the left shows the factor XI homodimer consisting of 4 apodomains shown in gold, magenta, green, and blue ribbons, and a catalytic domain. Together, they form a cup and saucer configuration, with the 4 apodomains forming the saucer and the catalytic domain serving as the cup inside the saucer. Figure B shows the ligand binding sites of the 4 apodomains and the catalytic domain. For example, A1, A2, and A4 domains mediate binding between thrombin and factor XI, whereas the A2, A3, and A4 domains mediate binding of factor XIIa to factor XI. Also note that the A3 domain binds with important components of the coagulation system, including factor 9 and also GP1B alpha on platelets. So this slide highlights the important role that factor 11 plays in coagulation. Upon vessel injury, there's the formation of the tissue factor 7A complex, which results in the first wave of thrombin generation and fibrin deposition. The small amounts of thrombin generated here activate platelets, factor 5, factor 8, and factor 11, triggering positive feedback loops, which feed on each other and enhance each other, resulting in a significant amount of thrombin being generated, the so-called thrombin burst, in the phase known as the clot amplification and propagation phase. So factor 11 plays a small role in the first wave of thrombin generation, the so-called tissue factor dependent phase, and this is shown in light purple. But factor 11 plays a pivotal role in the second wave of thrombin generation, the tissue factor independent phase of coagulation, which is shown in light orange. Factor 11 also plays a role in the regulation of fibrinolysis. The significant amounts of thrombin generated by the second wave of thrombin generation, of which factor 11 plays a key role, can activate TAFI, or thrombin activatable fibrinolysis inhibitor. Excuse the pointer again. Yep. So factor 11 plays an integral role in the amplification of tissue factor dependent activation or coagulation that results in pathological arterial and venous thrombosis. Factor 11 is also likely to play a key role in thrombosis associated with negatively charged surfaces, the so-called contact activation pathway. Such artificial surfaces in which thrombi can form include hemodialysis circuits, central venous catheters, as well as cardiopulmonary bypass. Hence, the role of factor 11 is to enable and sustain thrombin generation in the tissue factor independent phase of coagulation. Factor 11 also attenuates fibrinolysis via the action of thrombin in inactivating TAFI. Factor 11 also inactivates tissue factor pathway inhibitor, or TFPI, which enhances procoagulant activity. As a result of the roles and properties of factor 11, it is an attractive target for anticoagulant therapy as it plays a key role in pathological thrombosis, but only a minimal contribution to preserve hemostasis, i.e. in the first wave of tissue factor dependent thrombin generation. As a result of this, factor 11 deficient patients are protected from VTE and ischemic stroke, and also the formation of thrombi in artificial surfaces such as hemodialysis circuits. Importantly, for the purposes of this talk, the role and character of factor 11 is such that factor 11 deficiency is associated with a milder bleeding phenotype and not typically associated with spontaneous or critical site bleeding. Bleeding also tends to happen more frequently in areas of high fibrinolytic activity, such as the oral and urogenital tract. Just a bit of history regarding factor 11 deficiency. It was first discussed by Rosenfeld and colleagues in the 1950s. The seminal paper published in Blood is shown here on the right. Rosenfeld observed bleeding related to surgery and dental procedures in both men and women of a Jewish family. Plasma from these family members showed correction of the coagulation defect when mixed with plasmas obtained from hemophilia A and hemophilia B patients, suggesting a different factor deficiency. In view of this, factor 11 deficiency is also known as Rosenfeld syndrome or hemophilia C. The factor 11 gene is located on chromosome 4. The prevalence is thought to be 1 in a million for the autosomal recessive form, more frequent 1 in 30,000 for the autosomal dominant form. However, the figure is likely to be higher than this in view of underdiagnosis, underreporting, and underestimation by global surveys compared to national registries. For example, using national registry data, the prevalence of factor XI deficiency in the UK is reported as 1 in 16,500. The reason why factor XI deficiency is underdiagnosed and underreported is because many patients with factor XI deficiency have normal APTT, have minimal bleeding, and often no treatment is required. This means that these patients are not likely to be further investigated with confirmatory testing of factor XI deficiency. Factor XI deficiency is most common in the Ashkenazi Jew population. Clusters of factor XI deficiency are also seen in the UK, Ireland, and the French Basques, likely related to the founder effect. Severe deficiency is defined as a factor XI activity of less than 20 units per deciliter. Partial deficiency is defined as a factor XI activity between 20 and 60. The word severe here relates more to lower factor XI activity rather than the severe bleeding phenotype. Patients with severe deficiency usually are homozygous or compound heterozygous for pathogenic variants. There is a very weak correlation between bleeding and extent of factor XI deficiency in factor XI deficient patients. This is seen by this table. Factor XI has the weakest association between extent of factor deficiency and clinical bleeding out of all the factors that are listed here in this table. This is further highlighted by this table, which is from a publication by Flora Pandi and colleagues in JTH in 2012. The figures relating to factor XI deficiency are seen between the two red asterisks. On this table, it shows the factor level seen in patients with asymptomatic, i.e. no bleeding, seen in this column here, patients with grade 1 bleeding, i.e. trauma-related bleeding, this column here, patients with grade 2 bleeding, i.e. spontaneous minor bleeding, which includes bruising and ecchymoses, and patients with grade 3 bleeding, which is spontaneous major bleeding, for example, intracranial bleeding. These amounts are shown for various factor deficiencies, as can be seen by this column here. You can see that the factor level of factor XI observed in patients with no bleeding, i.e. 26, is identical to the factor level observed in patients with grade 3 or spontaneous major bleeding. This is very different to that of fibrinogen, factor 10, and factor 13, where the factor level clearly is reduced as you progress towards more severe bleeding from 31 in asymptomatic to 0 for patients with factor 13 deficiency. The variable bleeding phenotype characterized in factor XI deficiency can be seen even in individuals and may be explained by coexisting hemostatic defects, which include platelet defects, von Willebrand's disease, and variation in TFPI levels. While factor XI deficiency affects men and women equally, women have more frequent symptomatic bleeding. Bleeding in patients with factor XI deficiency tends to occur after hemostatic challenges such as surgery shown here, rather than occurring spontaneously. Joint and muscle bleeds are rare. Bleeding also tends to be more frequent and more severe in areas of high fibrinolytic activity, such as the oral mucosa shown here. Testing for factor XI deficiency is recommended in patients with a known family history, especially of a pathogenic variant, patients of high-risk demographic groups like the Ashkenazi Jews, and patients with unexplained and recurrent bleeding in the setting of trauma, surgery, or in areas of high fibrinolytic activity. Initial testing involves full blood count, prothrombin time, APTT, thrombin time, and fibrinogen. And a prolonged APTT with normal results of the above-mentioned tests would exclude anticoagulant contamination of the sample And the next step would be measuring the activities of the intrinsic factors, factor 8, factor 9, factor 11, and factor 12. The intrinsic pathway, like the extrinsic pathway, lead to the common pathway, which culminates in the formation of a fibrin clot. The key players of the intrinsic pathway are factor 12, factor 11, factor 9, and factor 8. Hence, an isolated prolonged APTT with normal factor 8, factor 9, and factor 12 levels is suggestive of factor 11 deficiency, and this can be confirmed by performing a factor 11 activity assay. It is important to note that the endpoint of the APTT test, the clotting endpoint, occurs with generation of very minimal amounts of thrombin, like 5% thrombin. Hence, it does not evaluate the tissue factor-independent thrombin generation and amplification phase in which factor 11 plays a key role in. Hence, APTT does not reliably assess bleeding risk in factor 11 deficient individuals. It is also important to discuss factors influencing APTT sensitivity to factor 11 deficiency. There are a wide range of APTT reagents available using different activators such as allergic acid, kaolin, and silica. Also, different phospholipid components from different sources, which can be animal or vegetable, can also be mixed in varying ratios with APTT reagents. Pierre Toulon and his French colleagues published this paper titled In Vitro Sensitivity of Different APTT Reagents to Mild Clotting Factor Deficiencies in the International Journal of Laboratory Hematology. Now, factor sensitivity or responsiveness is defined as the factor level at which the APTT is prolonged above the upper limit of the established reference interval. This study assessed 5 different APTT reagents, and the figures applicable for factor 11 levels are shown here between the red asterisks. As you can see, responsiveness or sensitivity varied from 38 to 52 units per deciliter, with the Hemosil APTT-SP having the highest sensitivity. Depending on which reagent is used, patients with factor 11 levels between 30 to 50 units per deciliter and a bleeding phenotype could have a normal APTT. Low factor 11 activity can be due to a quantitative factor 11 deficiency or a factor 11 inhibitor. The addition of pooled normal plasma to a patient's plasma in what is known as mixing studies can distinguish between the two. Rosner's index is a common method used to assess for the presence of an inhibitor. The formula to calculate the Rosner's index is shown here. And if you get a result of 15% or more, it is highly suggestive of an inhibitor. A factor 11 inhibitor assay is performed in a similar way to the factor 8 inhibitor assay, with incubation occurring at 37 degrees Celsius. The factor 11 inhibitor are usually immediately acting and not time dependent. Another way that a factor 11 inhibitor can be shown is with the demonstration of non-parallelism, seen by the line here in green, when compared to a standard curve, which is shown in blue, as well as curves of factor-deficient patients, shown here in orange and purple, when values of samples of various dilutions are plotted on a graph like this. The factor 11 activity assay is an APTT-based one-stage assay. Chromogenic factor 11 and immunological factor 11 assays are also available, but are not in routine use. The limitations of APTT and factor assays in assessing severity of bleeding phenotype in patients with factor 11 deficiency have just been discussed. In view of this, there's increasing research into GCAs, or global coagulation assays, which assess multiple physiological aspects of coagulation, including clot formation, thrombin generation and amplification, and fibrinolysis, with the potential to more accurately predict bleeding tendency in factor 11 deficient patients. I will now briefly discuss some of the global coagulation assays available. The first is the CAT assay, which is likely to be the most familiar one. CAT stands for Calibrated Automated Thrombogram. In this assay, tissue factor is constantly present and equally distributed in the sample mixture. Upon the addition of calcium chloride, parameters assessing thrombin generation are generated, including lag time, time to peak, peak height, which is the maximum amount of thrombin generated, velocity index, which is the rate of thrombin generation, and ETP, or endogenous thrombin potential, the area under curve, which indicates the overall amount of thrombin generated. Next is the ROTEM assay. ROTEM stands for rotational thromboelastometry. And in this device, citrated blood is placed in a disposable cup, which has a rotating pin in the middle, and this is spun. When the blood is calcified, the blood clots, and as clot firmness increases, the movement of the rotating pin is restricted. And it is this suppression of movement that is converted to parameters which can be used to assess coagulation, including CT, clotting time, CFT, clot formation time, MCF, maximum clot firmness, and ML, maximum lysis. So the ROTEM is very useful in the lab as it can provide a quick gauge of the extent of fibrinolysis. More modern GCAs include the turbidimetric assay, and as the name suggests, this assay measures clot properties by reading the optical density, which is a measure of turbidimetry of the clot forming over time. Samples are placed in a 96-well plate, and coagulation is activated by the addition of tissue factor, phospholipids, and calcium. Parameters generated by the turbidimetric assay are similar to that of ROTEM, and the CAT includes onset, time to peak, Vmax, and peak turbidity change. There's also the thrombodynamics assay, which can be used to assess thrombin generation and fibrin clot formation. A unique feature of the thrombodynamics assay is that tissue factor is immobilized on the surface, and coagulation can be triggered on that surface. Once coagulation is triggered, coagulation can move away from the immobilized surface to involve plasma, which lacks tissue factor. Hence, the beauty of the thromodynamics assay is that it can assess tissue factor independent coagulation, which factor 11 plays an integral role in. The parameters that are measured with the thromodynamics assay include amplitude, rate of growth, i.e. velocity, and clot size. The global coagulation assays are not routinely used, as there have been conflicting data regarding the utility of GCAs in assessing bleeding risk. It's also important to know that there is the lack of standardization of measurement parameters, i.e. which parameters do we use, and testing and sample conditions, including how much tissue factor should we use in these assays. The accessibility of specialized equipment and technology associated with the GCAs can also be difficult to obtain. There is some promising data emerging regarding assessing surgical risk of bleeding in patients with factor 11 deficiency, as well as evaluating their response to pro-hemostatic therapies such as factor 11 concentrate. This is from a publication by Bataglia Calderera, published in Thrombosis Hemostasis in 2021. The results are obtained by running of the thrombodynamics assay. The parameters used include AST, stationary amplitude of thrombin peak, V, which is the rate of clot growth, and CS, which is clot size. As mentioned before, this assay enables the assessment of coagulation in the tissue factor independent phase. Samples were obtained from healthy controls, C here in this column, as well as factor 11 patients who are non-bleeders, NB here, factor 11 deficient patients who have a bleeding phenotype B here, as well as factor 11 deficient patients with a prothrombotic phenotype shown as T here. As you can see, the values of coagulation used here is lower in the patients who bleed compared to the non-bleeders and the controls. And this is seen in all three parameters, as you can see here. Lower values for bleeders compared to non-bleeders and control patients. Also, the values for the prothrombotic phenotype is higher than that of the controls, as can be seen here, and seen here. Together with other studies, the data suggests that the factor 11 deficient patients who bleed have reduced fibrin network density, have a reduced rate of fibrin formation, and have lower clot stability, which may contribute to the observed bleeding. There was also a lack of correlation of the thrombodynamic parameters with factor 11 activity. I will now discuss molecular genetics. The factor 11 gene is located at chromosome 4q and consists of 15 exons and 14 introns. Most variants result in an equal reduction in both factor 11 antigen and factor 11 activity levels, the so-called quantitative type 1 deficiency. These include nonsense variants which affect transcription. One of the most well-known ones is the E117 stop mutation, which I will describe later. These can also include missense variants that disrupt dimerization through the apodomains. And one of these mutations is the F283L mutation, which I will also highlight in upcoming slides. These variants can also include variants that result in non-secretable homodimers. The mutations that result in a disproportionate reduction in factor 11 activity compared to antigen are much less frequent. The qualitative type 2 deficiency. The resultant protein produced is dysfunctional. Factor 11 gene analysis is usually uncomplicated in view of a lack of interfering sequences such as pseudogenes or GC-rich regions. Single nucleotide changes can be readily detected with dideoxynucleotide sequencing and next-generation platforms. Larger deletions can be detected with multiplex ligation-dependent probe amplification, or MLPA, or through read depth analysis in next-generation platforms. Variants in non-coding sequences remain challenging to detect, and to date, no complex rearrangements have been described in the factor 11 gene. Now, this is a figure that shows the frequency of the different types of factor 11 mutations. Missense mutations are the most frequent and account for greater than 50% of all mutations. 15% of mutations are intronic. This is a figure that shows the frequency of factor 11 mutations according to the domain that they affect. The most frequently affected domain is the serine protease domain. The other mutations are distributed quite equally among the remaining 4 apodomains, with the frequency around 15%. This table highlights some of the more common mutations, the domain that they affect, and also whether they are associated with a bleeding phenotype. For example, the C38R mutation affects the A1 domain and is the founder mutation in the French Basque population. As alluded to earlier, E117 stop affecting the A2 domain and F283L affecting the A4 domain are two of the most common mutations affecting Jewish patients. I will now provide more detail regarding these two mutations. The E117 stop mutation is a type 2 variant affecting the A2 domain. The presence of a premature stop codon results in absent or very reduced factor 11 levels, whereas the F283L mutation is a type 3 variant which results in impaired dimerization and secretion of factor 11 and affects the A4 domain. Homozygosity for the E117 stop mutation results in factor 11 activity levels close to zero, whereas homozygosity for the F283L mutation results in a factor 11 activity level of around 10 units per deciliter. Patients who are homozygous for the E117 stop mutation are at risk of factor 11 inhibitor formation, and this affects a third of this particular mutation group. Bleeding does not correlate consistently with the genotypes. However, more bleeding is observed in patients with the E117 stop mutation homozygosity than homozygosity or compound heterozygosity of this mutation with the F283L mutation. Hence, molecular testing of patients is recommended in patients with near absent factor 11 levels, particularly within the Ashkenazi Jew population, as it may point to a more severe bleeding phenotype and is associated with inhibitor formation. I will next discuss clinical aspects of factor 11 deficiency. Important considerations for clinical assessment vary depending on the age of the patient and also vary throughout a patient's life. Factor 11 levels reach adult levels in 6 months, and it is now generally accepted that factor 11 levels are not affected by menstruation or pregnancy. The trigger to bleeding very much depends on the age of the patient, with tonsillectomy being a primary trigger in children, postpartum hemorrhage in females of reproductive age, and urogenital surgery in older patients. Thrombosis also becomes a more important issue in the older patients. They may well be protected from VTE, stroke, and possibly also coronary artery disease by virtue of having factor 11 deficiency. There are many factors affecting management of bleeding and surgery in factor 11 patients. The most important of this is history of bleeding. This is the strongest predictor of bleeding. Past bleeding predicts future bleeding. Hence, it is important to perform an accurate history to determine the response of the patient to challenges such as trauma, surgery, dental procedures, pregnancy, and childbirth, and also to note if there's been any spontaneous bleeding. If there's a patient who is actively bleeding or is about to face surgery, it's important to know whether the bleeding is major or minor, or whether the surgery is major or minor, as this very much affects the management plan. The site of bleeding or surgery also impacts on clinical management. If surgery involves sites of high fibrinolytic activity, such as the oral, nasal cavities, the urogenital, and the GI tract, they are more at risk of bleeding. The factor 11 activity level plays a role as well in clinical decision making, as does the presence of inhibitor, as you would avoid exposure to exogenous factor 11 in patients with an inhibitor. Cardiovascular and thrombotic risk factors also merit consideration, as products such as factor 11 concentrate have a thrombotic risk. We'll now run through the treatment options available to medical staff who look after patients with factor 11 deficiency. The first treatment option is watch and wait, and this is suitable for many patients with partial deficiency, particularly if they have no bleeding history. The advantage of this strategy is that there's no exposure to blood products and hence no risk of allergic reactions and thrombosis. However, as there's a very weak relationship between factor 11 activity and bleeding may occur with this strategy of watch and wait. The next treatment option that I will discuss are the antifibrinolytics, which include TXA and E-aminocaproic acid, or EACA. The dose of these medications are listed here. The main indication of TXA is for oral cavity bleeding and dental procedures where it can be used as single therapy. This is also helpful in the prevention of postpartum hemorrhage and heavy menstrual bleeding. TXA and EACA can also be used as adjunct treatment combined with FFP or recombinant factor 7A or Novo7. The main disadvantage with TXA is thrombosis. In fact, the combination of factor 11 concentrate and TXA is not recommended because the combined thrombotic risk of these two medications is thought to be too high. TXA should also be avoided in genitourinary tract surgery or bleeding, as these drugs can promote clot formation and can result in urinary tract obstruction. The next two treatment options are sources of exogenous factor 11. The first is pathogen inactivated fresh frozen plasma or FFP, which can be treated by solvent detergents or with methylene blue. The dose of FFP given is listed here. It can be given every 24 to 48 hours as required, and its main indication is in major hemostatic challenges, i.e. surgery, particularly in patients with a history of bleeding. There is very minimal risk of viral infections as they are pathogen inactivated. The main disadvantages of using FFP are volume overload, hypersensitivity reactions, and risk of inhibitor development. There are two plasma-derived factor 11 concentrates available. One is factor 11 BPL, the other is hemo 11 LFB. There is no recombinant factor 11 concentrate. The dose of these products is listed here. The dose calculation of factor 11 units is very similar to that of calculating the amount of factor VIII concentrate in patients with hemophilia A. This product has a long half-life and can be repeated every 48 to 72 hours as needed. Its indication is again a major hemostatic challenge, particularly in patients with bleeding. And because we can calculate the dose to give, the rise in factor 11 is more predictable than FFP. The volume of infusion is also smaller. However, it does have the important disadvantage of thrombosis risk. Thrombosis has been observed causing fatalities in patients who have been exposed to factor 11 concentrate. This risk is somewhat mitigated by the addition of anticoagulant proteins such as heparin into these products. There's also the risk of factor 11 inhibitor development, and these products are not available for use in the USA. The last treatment option that I will discuss is recombinant factor 7A or Novo7. Note that the dose of Novo7 given, 15 to 20 micrograms per kilo, is lower than that given for hemophilia A patients with inhibitors. The indication for the use of this product is major hemostatic challenges in patients with an active factor 11 inhibitor or patients at high risk of inhibitor formation. Novo7 has the advantages of a small volume and rapid onset of action. Its main disadvantage is thrombosis risk, and also laboratory monitoring of its efficacy is not achievable with standard assays. Note that Novo7 is not FDA approved for treatment in factor 11 deficiency. So a factor 11 target of 30 to 45 is sufficient for most hemostatic challenges in patients with severe factor 11 deficiency. The aim should not be achieving a level of 60 to 70 in view of the risk of thrombosis. Most cases of heavy menstrual bleeding can be managed with antifibrinolytics on days where the periods are the heaviest. Another suitable alternative is hormonal treatments. Longer duration of use of antifibrinolytics is likely required for surgery involving sites of high fibrinolytic activity, such as the urogenital tract, duration of around 7 to 10 days, compared with surgery involving other areas, such as orthopedic surgery, where TXA can be used for 5 to 7 days. As factor 11 levels reach adult levels at 6 months, circumcision can be delayed until the baby is 6 months of age if the factor 11 activity level at birth is less than 10. I will now discuss peripartum management of patients with factor 11 deficiency. Bleeding history remains the most important parameter guiding management in this patient cohort. A repeat factor 11 level at 32 to 36 weeks is recommended. There is no universal consensus in management of this patient group. Management can range from expectant management for delivery and postpartum hemorrhage to using single therapy or combination of the following treatments: antifibrinolytics, FFP, factor 11 concentrate, or recombinant factor 7A. Note that the combination of factor 11 concentrate and TXA is not recommended. What is highly recommended is a multidisciplinary approach involving obstetrics, anesthesia, and in hematology in managing pregnant patients with factor 11 deficiency. There's also wide variance in thresholds of factor 11 levels for neuraxial anesthesia, or NA, in clinical practice. Peterson et al. Reported NA being placed at a range of factor 11 levels from 5 to 74 units per deciliter, a wide range of factor 11 activity indeed. Reassuringly, there were no epidural or spinal hematomas. In another retrospective case control study, 51 NAs were performed with factor 11 activity levels between 20 to 70 with no observed complications. Only 3 patients received prophylaxis of FAP, 1 with concomitant TXA. The responses in the French survey regarding factor 11 threshold ranged from 30 to 60 units per deciliter. This is the recommendation for the management of pregnant factor 11 deficient patients as outlined by the British Society of Hematology, or BCSH. It takes into account the factor 11 activity as well as a history of bleeding. So in patients with severe factor 11 deficiency with an activity of less than 15, for delivery, the recommendation is to consider use of factor 11 concentrate or SDFFP at established labor or before C-section. If the patient has a factor 1 activity level of between 15 to 70, i.e. partial deficiency, and a history of bleeding, the recommendation is to consider TXA as sole treatment for at least 3 days. And in patients with partial factor 11 deficiency with no history of bleeding despite hemostatic challenges, management is expectant with factor 11 concentrate or TXA only for consideration if excess bleeding occurs. These are the recommendations from the Royal College of Obstetrics and Gynecology in the UK, and they have a similar expectant management slant like the BSH. They stress that delivery plans needs to be individualized and consideration given to prophylactic factor 11 replacement in patients with severe deficiency or patients with a previous history of bleeding. Otherwise, management can be expectant. The college also commented on epidural anesthesia, or NA. Their recommendation was that it should not be performed in women with severely low factor 11 levels or patients with a known bleeding phenotype or when the bleeding phenotype is not clear. In patients with a non-bleeding phenotype, epidural anesthesia can proceed after a thorough discussion of the risks and benefits of doing an epidural in this patient cohort. This is a management algorithm issued by a group of physicians in Manchester, and I will highlight the important points of this flowchart. Firstly, all patients should have an assessment of previous bleeding history and a baseline factor 11 activity level. Next, a factor 11 activity level should be performed at 32 weeks to optimize planning for delivery. Management is then dependent on whether the factor 11 level is less than 20 or above 20. If it is less than 20, the recommendation is to administer prophylactic FFP. The preference is for prophylactic FFP rather than factor 11 concentrate in view of the narrow safety margin and thrombotic risk associated with factor 11 concentrate. If the factor 11 level is greater than 20, the recommendation is not to give prophylactic FFP. Also, management of postpartum hemorrhage is expectant with tranexamic acid given only if there's abnormal bleeding. This flowchart also states acceptable threshold of factor 11 activity of 40 or more for an epidural or spinal anesthesia to be performed. And lastly, this is the recommendations for delivery from the French Reference Center for Hemophilia and Rare Coagulation Disorders. And again, the recommendations take into account the factor 11 activity level and whether or not there's a history of bleeding. So in patients with severe factor 11 deficiency with no history of bleeding, the recommendation is for TXA to be given during delivery and to give factor 11 concentrate only if there's excess bleeding. And in patients with partial factor 11 deficiency for delivery, only give TXA and factor 11 concentrate if there is abnormal bleeding. The French group also quoted a threshold of 30 units per deciliter for epidural anesthesia in factor 11 deficient women with no history of bleeding. I will lastly discuss factor 11 inhibitors. So patients with a near absent factor 11 level as a result of inheritance of a null or nonsense mutation are at the greatest risk of inhibitor development upon exposure to exogenous factor 11. The highest frequency, as discussed previously, is seen in homozygotes for the E117 stop mutation. Management is defined by judicious use or avoidance of factor 11 containing products, including immunoglobulin. There have been reports of inhibitor formation in patients exposed to rhesus immunoglobulin, and management also encourages use of alternative products such as Novo-7 and antifibrinolytics. A factor 11 inhibitor is suspected with a lack of increment to exogenous factor 11, for example, factor 11 given post-major surgery. Importantly, bleeding is not worsened by the presence of a factor 11 inhibitor, and spontaneous bleeding is rare. Hence, immunosuppression is rare in order to manage this condition. Alloantibodies that form upon exposure to exogenous factor 11 usually demonstrate type 1 kinetics, i.e. linear inactivation of factor 11 activity by antibody. The kinetics of autoantibodies directed towards factor 11, which has been reported in patients with autoimmune conditions, pregnancy, and low-grade lymphoma, is not clearly defined. This article, published in 2024, describes the experience of a large center in the UK regarding their patient cohort of patients with factor 11 allo inhibitors. The following table describes the patient characteristics of the patients who develop a factor 11 inhibitor. 7 out of 103 patients, i.e. 6% of patients with severe factor 11 deficiency developed a factor 11 inhibitor. All patients in whom genomic analysis was done, they were homozygous for the E117 stop mutation. 6 out of 7 patients received factor 11 concentrate. And testing for inhibitor occurred routinely post-major surgery, or there was a poor increment to factor 11 level in the perioperative setting. Inhibitor testing was also done in patients who developed allergic reactions to factor 11 concentrates. The peak inhibitor titer varied from 1.6 to 41. This table outlines the surgical experience in patients who developed factor 11 inhibitors, which occurred in 5 out of 7 patients. All patients received concomitant tranexamic acid with factor 7A. Note that the factor 7A dose is variable from the 90 micrograms per kilo seen, which is similar in dose in patients with hemophilia A with inhibitors, compared to lower doses at 30 micrograms per kilo. There was no unexpected or excessive bleeding seen in any of the procedures. No patients received VTE prophylaxis routinely. However, one patient did develop a PE on day 5, which was treated with prophylactic low molecular weight heparin, followed by low-dose apixaban. So the key points from this important paper are that there was a 30% prevalence of inhibitor development in patients homozygous for the E117 stop mutation. This figure increased to 50% in this patient cohort who were also exposed to exogenous factor 11. This study highlights the importance of genomic analysis and monitoring for both factor 11 response and inhibitor formation in patients with very low levels of factor 11 who have received exogenous factor 11. Allergic reactions to factor 11 replacement may predict development of a factor 11 inhibitor. This was seen in one of the patients in this study, and this is similar to hemophilia B patients receiving factor 9 concentrate. And finally, lower doses of factor 7A is recommended and for it to be used for the shortest duration. Interestingly, the patient who developed PE had the longest duration of treatment of Novo-7 and had the most frequent doses of Novo-7 used. So to summarize my presentation, factor 11 deficiency usually has a mild bleeding phenotype, as factor 11 plays a minimum role in the first wave of tissue factor-mediated thrombin generation. There is a very weak relationship between clinical phenotype and factor 11 level. The APTT does not properly assess the role of factor 11 in coagulation, as it does not examine the tissue factor-independent phase of coagulation, which factor 11 plays a key role in. There is increasing reports of the usefulness of GCAs or global coagulation assays in predicting bleeding tendency in patients with factor 11 deficiency and to assess their response to treatment. Molecular testing is most useful in patients with near absent or absent factor 11 levels. The history of bleeding is the most important factor in determining clinical management. Management is individualized and can often be expected in patients without a bleeding history. Factor 11 concentrates have a risk of thrombosis, and antifibrinolytics and TXA are very useful as sole treatment for minor procedures and as an adjunct in major surgery. And lower doses of recombinant factor 7A can be used in patients with a factor 11 inhibitor. Before I finish my talk, I am from Australia, and I would like to encourage all of you, if you have time, to visit Australia, where you can meet cute and furry koalas. You can also see beautiful views of Sydney Harbour and visit the Sydney Opera House. And also, if you come to visit Adelaide, you can visit Kangaroo Island, which is known for its amazing rock formations and incredible sunsets. And depending on the time that you visit Kangaroo Island, a group of friendly penguins may greet you. Thank you for your attention, and I'm happy to take questions.
Thank you, Chee Wee, for this wonderful talk. It was a very good and complete overview of the factor 11 deficiency, the pathophysiology, the diagnosis, the treatment. Thank you very much. I'm looking now at the Q&A chat. I see a question in it, and the question is the thrombosis risk of factor 11 replacement dose dependent, and do we have a target or a certain level?
Yeah, so I think it's very likely to be dose dependent. And also the target level, yeah, so some, as you can see from the guidelines, some guidelines recommend the use of FFP rather than factor 11 concentrate because this eliminates the use, eliminates the risk of thrombosis and also enables TXA to be used concurrently. Most guidelines recommend a target of around 30 to 40 would be sufficient for major surgery, rather than aiming for a normal factor 11 level of between 60 to 70, as the risk of thrombosis increases if you aim for that high level with minimum gain. So the target level usually for major surgery is 30 to 40 and not any higher in view of the thrombotic risk.
Okay, thank you. Awaiting more questions, I have also a question from the laboratory diagnosis part. So you have nicely shown that the sensitivity of the APTT reagents is very different for factor 11 deficiency, or the level of factor 11. This is also known for other coagulation factors. But we also use in our one-stage clotting assay, of course, the APTT reagent. Is there known what reagent is the best to use in the one-stage clotting assay then? Maybe depending on the activator that is used to have a more predictive level of factor VIII for bleeding, or is this completely not achieved with the reagents that we now have?
Yeah, this is a very relevant question, and for this. So, a few thoughts on this issue. So, sensitivity is tricky because if you have high sensitivity, you could lead to false results, and you have low sensitivity, you could have too much workload as well. So, you could miss factor 11 deficiency if your sensitivity is too low. So, yeah, it's a tricky one. And I think ABTT, as you know, there's a lot of variability. And I think each lab has to probably spend the time to get a range appropriate for the combination of reagent plus analyzer plus activator. So I think I would probably recommend to make sure that your QC is good for your particular combination of reagent plus activator plus reagent. But it's tricky because if you dabble with sensitivity, you could have either false negatives or false positives, depending on how you go with sensitivity.
Okay, thank you. The next question is acquired factor 11 deficiency. So in fact, autoantibodies against factor 11. This is rather rare, I suppose. Can you comment on that, please?
Yeah, so there's not much literature on this, and I think the associated conditions are very similar to that that you see for acquired hemophilia A, i.e. pregnancy, autoimmune disease, lymphoma, malignancy. Yeah, there's not much literature on this, but their kinetics are usually not linear. They're very hard to predict bleeding. I think similar to that with factor VIII, acquired factor VIII inhibitors.
Yeah,
So
thank
we
you.
await more reports on this acquired factor 11 inhibitors.
Yeah, thank you. Next question is, how does the severity of factor 11 deficiency influence the risk of bleeding during surgery or dental procedures?
Oh, say that again. Well, how does the severity?
The severity related to the bleeding risk in surgery and dental procedures.
Yeah, this is the enigma of factor 11 deficiency, where two people can have the same factor 11 level. One can bleed a lot during surgery and one doesn't bleed at all. So it's very tricky. So the most reliable predictor of surgery would be past bleeding. So it's very important to do to take an accurate history of the extent of bleeding that the patient has been exposed to with past hemostatic challenges. So yeah, it's very hard to predict the risk of surgery. One, as mentioned before, can aim for a level of around 30 to 40, which is usually sufficient for most major surgeries. And it's also hoped that the global coagulation assays, via assessing thrombin generation, can provide more information on whether who bleeds or who doesn't bleed before these patients undergo major surgery.
Okay, thank you. Another question, I think everybody is struggling with the discrepancy between the level of factor 11 and the bleeding tendency. That's always frustrating, of course. And the next question is also on that point. So how can these discrepancies between factor 11 activity levels and the bleeding tendency be explained in the laboratory assessments?
Like
Is there an explanation for it that does not correlate?
Um, yeah, so I suppose it can go back to the role of factor 11 in that, yeah, it doesn't play a major role in the first wave of thrombin generation, but it plays a major role in in um in the secondary wave of thrombin generation. And the secondary wave is such a broad phase because so much thrombin is generated that the factor 11 may impact on how much the thrombin burst is, and that varies from patient to patient, perhaps. And also, it has been noted that patients with factor 11 deficiency often have concurrent defects, for example, von Willebrand's disease and platelet defects. So that also modulates the severity of bleeding. So another useful point here is to screen for other coagulation defects because this could impact on the bleeding phenotype that a patient experiences. And another emerging one is TFPI. Factor 11 plays a role in the modulation of TFPI. And again, TFPI function and levels may vary from patient to patient to account for the different bleedings that we see in patients with factor XI deficiency.
Yeah, thank you. And on the last question is in fact also related to that. So a patient with a factor XI level of 55% who develops a bleeding after tonsillectomy, is this a factor XI deficiency or not? And maybe I can add something to that question, because you nicely also showed the role of the genotyping in factor XI deficiency. And there I have the impression the relation is not optimal between the genotypes and the bleeding tendency, but probably better to predict bleeding than the factor XI measurements that we do. So, and although it is recommended to do the genotyping in patients with absent or near absent factor XI levels, shouldn't we do not more genetic testing to confirm a congenital factor XI deficiency?
Yeah, so again, I think it goes back to the question on how severe the bleeding. Well, so what was the question again? Was it severe? Was it the
Yeah,
relationship
the
between
question
bleeding
was
and
a patient with a level of
55?
55% of factor
Yep,
XI with a bleeding after
yep,
tonsillectomy,
yep,
no other bleeding symptoms. Is
yep.
that a factor XI deficiency or not?
Yeah, yeah. We face these dilemmas every day in clinical practice because it is not unusual as well to bleed after tonsillectomy. So, although it's not intended, but again, I think for that situation, you would hope that there's other hemostatic challenges that the patient has been exposed to, where you can gauge more accurately the bleeding phenotype for the patient. It also depends, I suppose, how much bleeding occurred after tonsillectomy. Like, was it life-threatening bleeding, or was it was it not life-threatening? But I agree that's a very difficult question that we face in practice every day, because tonsillectomy is one of those surgeries that can induce bleeding, which may not be unexpected. With regards to your question, should genotype testing be done more often? I think if we do more genotype testing, we will find out more about the relationship between genotype and bleeding, and that is always helpful information. So I think if there's capacity to do more genetic testing, I would recommend that. As you mentioned, the genetic testing is more relevant for patients with severe factor XI deficiency, but then again, a patient with a very low factor XI level may not bleed, whereas a patient with a factor XI level of 20 to 30 may bleed profusely. So I think there are a lot of areas of research that that is very much desirable in answering these important questions.
Yeah. Okay, thank you. So we have to close now this webinar, but I first want to thank the organizers for their technical support. Of course, you, Chee Wee, as a speaker for your wonderful talk. And I also want to thank all the attendees. Thank you, and I hope to see you back on April 1st for our second webinar.
Thanks, everyone. Thanks, Katrien.
Bye.